Let's kick it off.
Hello, everyone. Can you hear me well? All right. You know, I think that we need to have one of those recordings of the Jeopardy theme song, you know, the countdown, so everyone understands that it's time to gather around. I am so honored to be here today. I'm going to just start by just quickly introducing myself. I lead healthcare and life sciences for ConsenSys. That's ConsenSys with a Y, not the event with a U. And I also wear a number of other hats in industry that are elucidated here. I'm very proud to share a standards activity at IEEE for blockchain and healthcare and life sciences. I chair the healthcare special interest group at the Enterprise Ethereum Alliance, and I'm a huge fan of the organization HIMSS, the Health Information Management Systems Society, where I co-chair the blockchain task force. And just generally, I'm a glutton for punishment for volunteer work. And I'm working on that, but this is such a complex area, and there's so many different groups of stakeholders that need to be aligned. It's certainly a bigger task than any one private for-profit corporation could ever hope to do alone. So, moonshots. I want to talk to you today about how to get into a moonshot mindset. And my belief is that for us to take the fullest advantage, for the benefit of humanity, all of the converging innovations just before us, we have to begin to think bigger, think differently, and become increasingly united around what we can achieve together for the benefit of humanity. So what defines a moonshot? I'm sure everybody's familiar with the history of the original moonshot. We decided that we were going to put a human being on the moon, and we made that decision at a time, but we had no idea how to accomplish that. We didn't know how much it would cost, we didn't know if it was even possible. It was so audacious, and that audacity is one of the first characteristics. The boldness, the willingness to go out on the edge and say, we're gonna get this done. And I don't know about any of you, but the possibility of being part of making history, that really moves me. And I think it moves a lot of people in this room and in this community too. So the other thing is, if you already know how you're going to get it done, then it's not a moonshot. It requires us to become humble, to open our minds, to move away from our arrogance, and to become experimental and iterative in our approach. And for healthcare and life sciences, that's the ethical way to approach it, and I'm going to be talking more about that. So it's also something that, in order to realistically happen, it probably is going to require some kind of substantive restructure of the way that we are organizing our human resources, our capital. It might even require some substantial sacrifices to get it done. So that's some of what you're starting to see happen in healthcare with some of these very large, ambitious consortia forming for the first time in history. Competitors coming together, lions laying down with the lambs. It's chaos, it's crazy. But here we have it, and it's happening, and we're at the beginning right now. I like this one because I'm a perpetual optimist, and I get made fun of, and I'm all right with that. Everybody can laugh at me all they like, because one of the things that defines a moonshot is that pessimists everywhere love to poke fun at it. So when you've got the haters and the naysayers saying, all these dream big people, let's get pragmatic, let's get serious. They're not moonshot thinking. They're not in the right mindset. And then finally, total commitment. It's something so audacious and so bold that you're sure it's going to fail unless you have the determination and the commitment of all the stakeholder groups. This is so difficult. This has only been achieved in human history a couple of times, and never on a global basis. Only in the context of, nationalist agendas in the Cold War. So we're talking about all of humanity here. So these are the mindset characteristics that I ask you to try to hold in your consciousness as we go through this next 30 minutes. And my goal here is to just unpack a point of view about the future of healthcare and life sciences. What can it look like? It's not about any one moonshot. It's about how do we come together with this kind of attitude to achieve the things that we're going to decide we're going to achieve, no matter what. Failure is not an option. We're not going to continue to go forward as a species with these terrible inequities in access and outcomes from a healthcare perspective. We are not going to allow the incredible scientific research to not be translated into practice. We just won't stand anymore for the current state, and I am not demonizing anyone in healthcare and life sciences. On the contrary, everyone who works in healthcare and life sciences is an army of people full of heart, and these people are waking up, and they are passionate, and everyone is ready to finally engage in this transformation that we've been waiting for, we've been hoping for. So just a quick example of one maybe moonshot candidate. If you're not in this field, you may be unaware that there's one single data element out of millions of data elements that might define a certain person that is the most predictive of their life expectancy and a range of other determinants. In the United States, it happens to be zip code. Funny, isn't it? In Chicago, there's a 30-year spread of mortality levels based on zip code, just inside this one city. So would it be possible to use fourth industrial revolution technologies? This isn't just blockchain, this is convergence. I'm going to talk more about that. What if you could ethically eliminate those disparities and then have rising tides lift all boats? That's an example, a representative thing. So contextualizing blockchain in healthcare. So I think when we spend a lot of time in the blockchain and crypto community, just blockchain, kind of blinders on a little bit. But thinking about what else is going on, blockchain is not the only family of extraordinarily disruptive, revolutionary, paradigm-shifting technologies reaching maturity right now. There's many others, actually, and they're converging. It would be, I believe it's unprecedented in human history. It would be like the Gutenberg printing press and the steam engine and the integrated circuit all were somehow invented and hitting humanity all at once. And we stand here today trying to predict how it's going to impact us, trying to protect ourselves from risks and take advantage of benefits. It's incredibly complex. And meanwhile, our industry, healthcare and life sciences, we didn't grow up protecting ourselves from bad guys like banking did or like the government did. You know, we were a compliance culture, a check the box culture, not constantly under increasing, sometimes nation state level cybersecurity attack and increasing severity of those attacks. And now we have a connected health system and connected devices where the hacking of health information isn't just about selling identities on the black market anymore. Real harm can be done, really very serious harm. Patients can die, EHR systems can be shut down, medical devices can be hacked and manipulated. So the severity is also changing. And at the same time this is going on, something wonderful is happening in our culture. And it's not specific to healthcare in any way, but health data is inarguably the most valuable category of data. And there's no longer any doubt in anyone's mind that data has value. Even though we have no market-efficient functions for price discovery yet on data, we will. And health data is undoubtedly holds the potential to cure cancer, to cure aging, to finally move to real precision medicine to treat us as individuals. Well, we now have a tipping point that's occurred where we don't feel it's ethical or just or moral any longer to market anonymized health data without remuneration to the original data subject. And I predict, and I'm willing to go on record here, I predict that within 5 years, in every jurisdiction in the United States and most jurisdictions globally, our standard practice today of the way that we move around anonymized health data will be illegal everywhere. And we will move away from de-identified data that no longer, that we all know is easily re-identified now. Under the US HIPAA law, there's 18 data elements that have to be obfuscated from a record for something to be determined as officially de-identified. It's been shown in the literature that large-scale data aggregation now means that that can all be re-identified. And our entire regulatory and policy framework is built on this notion that de-identified data isn't PHI, protected health information. But the whole thing's, it's all the emperor has no clothes situation right now. And everyone's realizing that that's going to change. So we'll be moving away from the use of de-identified data And I believe and I hope that we'll be moving to identify data where it is self-sovereign, and the data subjects have the opportunity to choose how and when they are identified in hyper-granular, transaction-specific consent models. In the US, a huge regulatory forcing function is coming with the information blocking provisions, which is the last stage of implementation of the 21st Century Cures Act. Subject of a talk of its own, but incredibly impactful. It means there's finally going to be an external forcing function to drive the portability and liquidity of health data. That's going to be important for our industry. So everybody does a little bit of their blockchain 101. I want to share my point of view about what I think this actually means. And this is not intended to be super technical or abstract, but everything we're talking about with blockchain is built on top of Web 2, what we think of as Web 2. And it's not one thing. You've got at least these 4 layers that are, when we say blockchain, that's what we're talking about. And some of that is just old tech, used in very creative and novel ways. But importantly, these enable brand new business models. These technologies give us an opportunity to apply game theory and behavioral economic models and design to conceive of an experiment about the incentives that drive different stakeholder groups, execute that experiment, do it under a research protocol, and actually learn what's working to change a complex adaptive system. We have never had tools like that ever in the history of man, and that's not even about the technology at all. From our perspective, at ConsenSys Health, a really important part of this picture outside of and in addition to blockchain is this bucket of tech we call privacy in depth. That's because we had to come up with something to call it. These are not this is not one technology, but a laundry list of very important, critical privacy and security, so trusted compute, verifiable compute, a wide range of novel, including homomorphic encryption, off-chain. These things are all part of the toolbox and the frame of reference that we're looking at. And importantly, so is what we're calling decentralized AI. And so Google invented federated learning as a concept, and if you're not familiar, in brief, everything in our AI paradigm right now is about creating bigger and bigger data lakes with higher level of data quality, and then using it to train machine learning algorithms, right? Well, I believe we've sort of reached the logical extreme with what we can do with data lakes, and what we need to start doing is, instead of bringing data to where the algorithms live, we're going to bring the algorithms to where the data lives. And we're going to train at the edge, but it absolutely has to be blockchain facilitated as the access control layer, and for a number of other reasons, subject of a different talk. But it's all part of the frame of reference. This is just a point of view on what the ecosystem looks like. And coming out of the panel just ended, it's really interesting to see the implications for tokenization, the implications into financial markets, the convergence, importantly, of public and private networks. We view the Ethereum mainnet as a vital resource to provide discoverability, to provide security backstops for private networks and sidechains. And on the enterprise side, we are continuing to build a wide range of products, and ConsenSys Health has an exciting and not yet announced product roadmap to share with you in the first quarter of next year. So this is all so cheery and rosy and optimistic, but what are we really up against? I spent a fair amount of time trying to be an early adopter of these technologies in my past venture before ConsenSys Health. One problem after another, and I gained crystal clarity through failure and repetition about all of these barriers, all the things that stand between us now and the realization of this benefit. And this isn't even applicable to only blockchain. This is all of the fourth industrial revolution technologies in different manners. No time to talk about all of these, but you'll notice some of them are near and dear to my heart, like standards and certifications or conformity to standards and so on. 5 of these really rise to the top, and where we're choosing to prioritize our early work. And part of the reason is that I like to take on the challenges that everyone else kind of wants to avoid. And maybe that's a defect. But these are some of the hardest challenges, and Bioethics, privacy, compliance, cybersecurity, and identity are priority areas for us and areas where we think we will have contributions for the ecosystem broadly. And we're hoping that many of our partners and collaborators will be able to help us solve these incredibly difficult problems. One of those on the bioethics front, we haven't had a large-scale upgrade of bioethics and clinical research for a really long time. One of my colleagues at ConsenSys Health and his colleague at the Berman Institute for Bioethics at Hopkins published this paper on this concept of Belmont 2.0. And that's a brand new paradigm for bioethical research standards. We're really excited about that. And I'm going to take a few minutes to talk about identity because it's so foundational to everything we're doing. So I have developed the foundation for standards activities as well as specification of what I think. It's just my opinion, but it's informed with a lot of brilliant collaborators at IEEE and at ConsenSys and at the EEA and so on. Very specific to healthcare though. We first want to start with existing standards. We want to build on and extend the DID. And we need to then have a healthcare-specific metadata structure that's standardized so that we're able to categorize what kind of identity we're talking about, what sort of DID. Then we see secure compartmentalization of identity being vital. For example, if we don't wish to live under corporate or government overlords, and we don't wish to have, Skynet know our every move and predict our every decision before we make it, if that's not our desire, then what we need to do is have a mechanism to prevent the aggregation and the cross-sectional analysis of our inherent human data. That has to come back to identity, and we propose a network of non-fungible tokens that use advanced privacy tech to obfuscate the connectivity between the tokens. Then biometrics is vital. After all, we live in a meat suit so far. We haven't been uploaded to the cloud yet. And so long as we live in our meat suit, we have to connect to the physical body. So biometrics is a burgeoning field, also bioethically terrifying field. And we need a system of connecting different biometric attestations to this network of non-fungible tokens. Then identity is a spectrum. It's 1,000 shades of gray, but we don't have a standardized scale to identify what level of probabilistic certainty applies to this particular identity. And if you were going to pivot a workflow based on that certainty, how would you measure that? So we need that scale, and we have to come together on that scale. A term called embedded bioethics is really important to me. This is the idea of not only bioethical principles informing policy and governance and management and leadership, but also building bioethically relevant endpoints into monitoring and evaluation systems, being able to flag unintended consequences when they're happening so that we can intervene early and often and course correct on these large-scale systems. And then we also, nations around the world are rapidly rolling out digital identities, and we need to create some kind of connectivity that nation or national public sector actors can use in order to interface with an identity like this in a way that doesn't give them the opportunity to destroy every civil liberty that our culture happens to value. I definitely value. And then lastly, we have to, people are born and people die. That's so far our paradigm. We may have a future version of that, but we need to connect birth certificates and we need to connect death certificates. Because actually mortality data is a real challenge in healthcare. It's not simple to know how much you've extended someone's life if the data that they passed away is not immediately evident or accessible. It's expensive and it's difficult. So we have to know about birth, we have to know about death, and it all goes in this frame of reference. So, big vision for identity. This isn't about any one company. It's not about any one product. This is about an industry point of view. Hopefully there's a whole constellation of healthy competition of people that are building toward a standard that we think can actually work. So there's a lot going on in healthcare. I'm not going to go through all these things, but there's some of the most historically significant occasions of competing stakeholders coming together to solve problems. In the European Union, the Innovative Medicine Institute, there are 12 global pharmaceutical companies in a public-private partnership with the European Union. They have an ambitious agenda around clinical trials, health data exchange, and supply chain for the entire European Union market. It's well underway. It's an exciting program. The Synaptic Health Alliance, you can see the actors that have come together. They actually have production systems right now that are optimizing provider data directory. And the Health Utility Network, formed by IBM, Aetna, PNC Bank, Cigna, Centera Health, many others, also has an incredible point of view and is coming together in a utility model to move healthcare forward. The Coalesce Health Alliance is looking at something really wonky called shared accumulators and, in all the blues organizations, but there's a lot of action. We have the first authority to operate as a federal information system in the US government. Where did it come from? Healthcare, the Department of Health and Human Services, just this past December. We have all kinds of activities. I'm going to tell you more about blockchain and healthcare global and make an impassioned plea that you engage. And then we have platform-focused working groups that are thriving and engaging around Ethereum, around Hyperledger, around Corda, and so we're really seeing so much movement. And what are these people doing? What are you building? What's your thing? What's your use case, right? Well, there's not one important use case in healthcare. There's hundreds. And this is a deliberately disorganized, messy laundry list of stuff people are working on. And the more important thing than the details of this list is how in the world would you prioritize these things when all of them touch different stakeholders, the same stakeholders? How could you organize the capital? How could you deal with the change management? How would you even deal with the governance and the policy and all of these things? The industry can't do everything at once. So the thing that I began to crystallize on shortly after I moved into this space was that we have to have some kind of common mental model to think about the transformation of this industry. And so I developed this PHI readiness framework. And it juxtaposes the amount of PHI that is involved in any given use case over time, and population health impact on the y-axis, which is really what it's all about, right? That's the whole mission. That's what we want to see in healthcare. And broke it into 3 macro stages of transformation. Stage 1, we are well into stage 1, which is terrific. And what I may have been the first to observe, I don't know. That's kind of funny, kind of a funny thought, but the things that are getting traction, the things that are well into production, why is it that they have one common characteristic? They don't use PHI at all. They don't compute on, they don't transact with, they don't have anything to do with PHI. And so, that's kind of a boulder in the stream, right? Like, this is healthcare after all. We're gonna have to deal with, patients, right? So when you get over to stage 3, you're thinking about, well, now you've got not just PHI, but maybe sensitive PHI, which I think is going to become a legally relevant term. For example, the difference between whether I am HIV positive versus whether I am potentially late for my 6-month follow-up visit. Very different pieces of health information. Today, they're treated under the law pretty much identically. And also the degree of certitude that you have about these use cases. So those things under stage 3 are kind of our holy grail situations, the orchestration of clinical processes across organizational boundaries, the ability to actually deliver precision medicine. I'm really excited personally about these things called digital therapeutics. And for anyone in the room that's not in healthcare, a digital therapeutic is actually a doctor prescribable, insurance reimbursable mobile app indicated to treat a disease or condition by, in our country, the Food and Drug Administration. This started just a few years ago, and now there are more than 80 digital therapeutics in the FDA's pipeline. And my view is that we have an opportunity to take a Web 2 to Web 3 upgrade strategy for digital therapeutics that is going to be extraordinary. But, I didn't do my build-up about the big question mark in the middle. So what we have all those 16 barriers that we talked about earlier. All these problems, those barriers are what is between stage 1 and stage 3. Those barriers are the reason that in most regulated, developed health economies, you can't just do this stuff right now. So we need a strategy, we need a bridge, because we can't sit and wait, and we also have a great deal to learn. Back to the moonshot mindset. We need to be experimental, we need to be empirical in the way that we're thinking. So stage 2, I would argue, right now today, it is ethical, it is appropriate. I even think that we have a mandate to move forward with the use of so under a research protocol. And for those of you outside the space, it's like a walled garden. It happens, in the doctor's offices that you go to, but it has a different capital structure. The money flows differently. Patients become investigators. Patients become subjects. Providers become investigators. There is a separate regulatory framework. There is, importantly, something called an IRB that oversees it and approves not only all the aspects of the study and the protocol, but the technology infrastructure. What does the IRB approve that is so germane to our circumstance? They approve the technology infrastructure that's used to run the trial. And everything about the data governance, the cybersecurity, the compliance, that all is overseen by an IRB. So, absolutely critical strategic point. We should move forward briskly, and we should move forward ethically by organizing our work into studies that will allow us to generate benefit in more than one ways. So the area of clinical trials is one of the most rich areas of opportunity for the application of this technology. So we will be learning how the technology helps with the meta process of running a trial. Meanwhile, we will also be able to measure secondary and tertiary endpoints that look at how it impacted the outcomes. A few things that I'm getting low on time, so I'm going to go super, super fast forward here at the end. But there's a few common elements that all of this has to do, but patient-mediated data exchange, aggregation, curation, and monetization are foundational and are going to be, all of the stage 3 use cases ultimately get you back to that point. It's like a do not pass go, you end up back at meeting those capabilities. And I have a dear friend and colleague, Dr. Sean Mannion, who likes to talk about faster miracles. And I am so moved by his vision for faster miracles. And the average cycle time from bench to bedside is 17 to 25 years today. That means, basic science innovation or breakthrough to the point that you would show up, present with some condition, and your doctor would give you a treatment of some kind. We have the opportunity to move to affect every single major milestone from bench to bedside, importantly including some of the most efficient mechanisms for capital formation that have ever happened, and those are major barriers. The money side of the equation, it's a $14 trillion global economy, healthcare. That's $14 trillion in payments, settlements imagine, it's a lot. People don't think about that. But this thought that finance and healthcare are separate, it's not true. Ask JP Morgan. And so a little bit about the standard. If anyone wants to participate, it is an open standard. Please see me. We need engagement. We're looking for healthcare and life sciences domain experts. We don't need you to be a blockchain expert. And then this organization is also under the IEEE umbrella. It's a 501c6 that I co-founded and I chair its board. We want to form an industry self-regulatory function and advocate in a uniform way on behalf of our entire industry. We're not a standards development organization. That's firewalled. It happens in a separate part of the same IEEE umbrella. But we will propagate emerging standards. We will do certifications to conformity of those standards. And importantly, blockchain consortia are popping up all over the healthcare industry, all over the world. We hope this organization will be the convener of consortia to enable them to come together and have a global 185-year-old organization that's never had a scandal and that does business in 160 countries. A truly global, truly unbiased institution behind these activities. So I'm very passionate about this project. It's never going to make me a dime ever, but it's been a huge labor of love. Anybody in healthcare that wants to engage would love your volunteerism and your heart if you want to try to make these things happen. So a couple of closing thoughts for you on the moonshot mindset, and these are deliberately open questions. The first question is, who is, if we're going to decide on the moonshot, who is accountable for it? You know, in our historic moonshot example, it was a nation state, it was the United States government, but that's not going to work. We can't have our moonshots come out of individual nation states. We have to have all the stakeholder groups. So if it can't come solely from the government, how do we align industry and academia and philanthropy? It's not easy, it's never been done. And then, I love this is so central. The single most important question for us to ask ourselves in healthcare and life science is what can be removed from the basis of competition? What is currently part of organizations in the way they compete that could be simply moved out? There was a time that every factory everywhere had its own power generator before the power grid was built. Part of the basis of their competition as factories was whether their generator was working. Who had better generators made them more able to have production. Well, then there came a time when they decided to mutualize, to federate the need for electricity. And all of those factories turned off their generators and connected to a grid, and that leveled up the basis of competition. As a metaphor, that's the same kind of thing that we need to discover in healthcare. And the last question is, we have to know how sustainable and how effective our governance, security, and ownership structures are, not just for these infrastructures, but it's capital, it's risk. Risk has to be underwritten, right? Risk has to be allocated. It's technology itself that's being developed, separate entirely from these rich mines of data. And then finally, it's intellectual property and its role, which I am also predicting a huge, large-scale patent war to come downstream in our field. So those are the questions to leave you. And I hope you find yourself in a moonshot mindset, and thank you very, very much.
Thank you very much for such a dynamic, passionate presentation. And I'm really glad that you're helping to lead the thought leadership for healthcare and identity, and we really appreciate all of your wonderful work on that. So thanks, Heather. Okay. So next we're going to have Daniel Eaton from R3 presenting. And I had the pleasure of hearing Daniel's presentation in Toronto at Don Tapscott's event. And he really will give us a great update on what R3 Quarter is doing, and they're doing some great projects in FinTech, and hopefully he'll talk about Finastra and what they're doing with Finastra as well. So let's just take a look at the clock here. We're pretty much got about 5 minutes, so if you need to get a quick refreshment, do that, and we'll get Daniel all mic'd up and ready to go. Everyone, you should definitely look up Heather after her presentation here, because she will give you all the great answers. And we've had such a great focus on healthcare at the summit, and reach out to her. She'll be glad to talk with you and get you engaged. Thanks.
Everywhere. Look at him. That boy.